Richa,
Hello, sir. Good morning, sir.
what happened to you?
Nothing, sir.
I thought you finished your course and you're still logging on to our classes. Good.
Good morning, everyone.
Yeah.
Today's case presentation about a 50-year-old lady, Mrs. Rinku Rani Saha, who is a resident of Bangladesh, who is a housewife, presented with complaints of angina and exhaustion for 8 months and dyspnea and exhaustion for the past 3 months. Patient is a known case of rheumatic heart disease who was apparently normal 8 months back, and then she developed angina, which was insidious on onset and gradually progressive, which aggravated on exhaustion and subsiding with rest, which gradually progressed over past 8 months to class NYHA class 3. There's a history of dyspnea and exhaustion class 3 for the past 3 months. History of syncope 2 episodes in the last 2 months. History of PND in the last 2 months. No history of orthopnea. No history suggestive of infective endocarditis. And no history suggestive of heart failure. 27 years back, during her second pregnancy, she was diagnosed to have rheumatic heart disease and advised to take injection penicillin. She discontinued after taking for 15 years. In 2016, she developed dyspnea and palpitation, for which she was evaluated and diagnosed to have valvular heart disease. For the same, she was underwent PTMC in 2016. After that, she was asymptomatic till 8 months back. She's a known hypothyroidism for the last 4 years on thyroxine medication. Menstrual history, she attained menopause in the last 2 years. An obstetric history of P2, L2, and A1. It's a mixed diet, normal bowel and bladder habits, no addiction habits. No significant histories in the family. Past treatment history, she had taken injection penicillin for the last 15 years and stopped 6 years back. And she underwent PTMC at 2016. And currently she is on tab warfarin 2.5 mg OD and amiodarone 200 mg BD, tab digoxin and tab metoprolol, and diuretics furosemide and spironolactone, and thyroxine for the hypothyroidism. To summarize, a 50-year-old lady, a known case of rheumatic heart disease with status post PTMC, presented with angina and dyspnea and exhaustion in NYHA class 3 with paroxysmal nocturnal dyspnea, having left-sided valvular heart disease. General examination. On examination, patient is conscious, oriented, and cooperative, well-built and well-nourished. Height of 154 centimeter, weight of 60 kg, BSA of 1.6 meter square. Is pallor, no clubbing, icterus, cyanosis, edema, or lymphadenopathy. Vitals temperature of 98 Fahrenheit. Pulse rate of 68 beats per minute, irregular rhythm with varying volume. No radio-radial delay or radio-femoral delay. All peripheral pulses felt. There's a pulse deficit of 33 beats per minute. Central examination, BP 130 by 60 millimeter of mercury in right arm supine position and 150 by 60 millimeter in mercury in lower limb. Since there was a wide pulse pressure, I looked for the peripheral signs of VIA. There was no peripheral signs of aortic regurgitation. Saturation of 98% on room air, respiratory rate of 16 per minute, JVP not raised. Systemic examination and inspection, trachea appears to be in the midline, apical impulse visible lateral to the midclavicular line. No other scars or chest wall deformities. Palpation, apical beat is confirmed to be at 6th intercostal space, 1.5 centimeter lateral to midclavicular line, which is heaving in nature. No systolic thrill, no parasternal heave, or no palpable heart sounds. On auscultation, there is a loud S1 in the mitral area with a loud P2 in the pulmonary area. And in aortic area, the single S2, soft single S2 in aortic area. There's a low pitch rumbling mid-diastolic murmur heard in the apex, which is best heard in the left lateral position. And another grade 3/6 adjacent systolic murmur in the right second intercostal space, which is conducting to carotid. No other murmurs heard. Other systems, respiratory systems are bilaterally equal, no added sounds. CNS, no focal neurological deficit. Abdomen soft, bowel sounds, no organomegaly. Our diagnosis is 50 years old lady with status post PTMC. Now has severe mitral restenosis with severe aortic restenosis of rheumatic etiology in atrial fibrillation with controlled ventricular rate, with moderate pulmonary artery hypertension and no features of infective endocarditis and thromboembolic events, on anti-failure medications in NYHA class 3.
Anti-failure and also anti-arrhythmic. She's on anticoagulant also. She's on warfarin and codron also, no?
Yes, sir.
Okay. Why do you say this is severe mitral stenosis? Restenosis, right?
Stenosis. She already had one mitral stenosis for which she underwent PTMC in 2016. Now she again developed symptoms. In this, there is nothing snap, and the murmur duration, based on the murmur duration, it can classify as severe mitral stenosis. And she's having paroxysmal nocturnal dyspnea also, which is a sign of LV dysfunction. So severe mitral stenosis.
Duration of murmur you cannot make out very well because she's in AF. Yeah.
Yes, sir.
And also similarly, you will not get presystolic accentuation in this patient.
Yes.
So, well, because of the history, you might consider that this is restenosis, which may be because, and also may be severe. Okay. Why severe AS?
And then there was a murmur which was conducting to carotid, 3 basic ASM conducting to carotid. Second is single soft S2 in the aortic area.
Is there a thrill associated?
No, sir, no. I couldn't implement.
Hmm.
Would be moderate to severe, sir. So, since the MS mitral stenosis is there, might be aortic stenosis also might be under evaluated.
Okay. So, what do you want to do?
So before that, when a patient has got severe mitral stenosis and severe aortic stenosis, how does the hemodynamics work? Which lesion you may be underestimating in the presence of severe.
Aortic stenosis will be underestimating.
Huh?
We'll be underestimating aortic stenosis.
Because the stroke volume is much less, you are likely to underestimate the aortic stenosis. Similarly, in a patient with severe aortic stenosis, what happens to mitral stenosis clinical signs? There are two things there. One, a patient with severe mitral stenosis may go into atrial fibrillation much more than a patient with severe aortic stenosis. So that will change the whole hemodynamics. Then also, when there's severe aortic stenosis, you may also underestimate the mitral stenosis. That's because the concentric hypertrophy of the left ventricle, the relaxation of the left ventricle is affected so much so you can underestimate the mitral stenosis in all your echocardiography also. The best such things is to the planimetry may be able to give you a better idea. Even the pressure half time may vary. That's it. Very often you have to understand how hemodynamics vary because they are multivalvular disease. So in this case, you may be underestimated. So it's a mitral restenosis. And you said class 3, but this patient, you said not in failure, but you must say that because of the treatment probability, failure signs are not there. She's on spironolactone, placilectone, so it's antiarrhythmic. Okay.
I would like to investigate further to confirm my diagnosis and for further management. The ECG is a standardized 12-lead ECG, which showing atrial fibrillation with heart rate of around 110 per minute. With axis being normal axis with the axis of 40 degrees, sir, plus 40. And there is, since there is no P waves, I couldn't able to comment about the chamber enlargement of LA. And there is the V5, V6, there is a LV strain pattern, ST depressions and T wave inversions are seen. And there are no signs of LVH in the ECGs.
What are the signs of LA enlargement in AF? You must know this. If you don't know, you must find out. Okay?
Yes, sir.
It's important.
Okay,
You will
sir.
get a similar case in the exam and they will definitely ask you, is there
Okay.
LA enlargement?
Okay.
And does LA enlargement make any this thing? What is the relevance to you?
Surgically, I can plan whether I can go for a direct LA approach, or I may have to go for some.
Your exposure of the mitral valve is much easier when there is a gross LA enlargement. Yeah. Okay.
Chest X-ray, PA view will centralized and well exposed. So showing cardiomegaly with CT ratio of 0.6, with straightening of left heart border, with double atrial shadow and splaying of carina, the LV type of apex, increased bronchoalveolar noise. Sir?
It's got MS and AS.
Yes.
Is
Yes, sir.
cardiomegaly a usual phenomenon in such a combination?
No, sir. It's not a common.
So you missed something
Yes, sir.
in your clinical examination.
Yes, sir.
Yeah.
Yes, sir.
Okay. So that itself will give you a clue.
Yes.
And there is gross LA enlargement on the X-ray.
Yes. Yes, sir.
The double shadow is seen very well. Okay.
Yes, sir. Econ 2D Doppler, which showed mitral valve thickened leaflets with AML doming and PML mobility restricted, with anterolateral commissure mildly calcified and fused, with mild to moderate subvalvular fusion. Mitral valve area by planimetry is 1.4 centimeter, with gradient of peak gradient of 18 and mean gradient of 8 millimeter mercury, with mild MR. In aortic, it's a trileaflet, thickened and moderately calcified, restricted mobility, with gradient of 56 by 38 millimeter of mercury, with moderate AR. An aortic valve annulus is 18 millimeter, and ascending aorta is 33, with PA pressures of 46 millimeter of mercury. And other valves are a mild to moderate tricuspid regurgitation, with a left atrial size is 52 mm, and significant LVH, with a LVAD of 45 and IVS of 16.
So which is the most significant valvular lesion according to your echo? What's the mean
Aortic
gradient
stenosis.
across the yeah. So the mitral valve mean gradient and you said valve orifice area 1.45 or something, is it?
Yes, 1.4, sir.
So that's not the most significant reason. So the most significant reason is aortic stenosis in this case.
What's the aortic annulus?
18 mm, sir.
Okay.
So what is the etiology you said? In this case, it's very obvious. Otherwise,
Yes, in this case, it's IVS.
how do you decide what's the etiology of a valvular heart disease? Or in other words, when rheumatic heart disease, what is the incidence of affection of mitral valve, affection of aortic valve, affection of combined mitral plus aortic valve disease, and tricuspid valve and pulmonary valve? What's the usual statistics for the rheumatic heart disease affection of each valve?
Isolated aortic valve involvement is less than 5%.
Very, very, very rare. Okay, good.
Very
But you don't start like that. You say, what's the common incidence?
common sense mitral valve.
Yeah. How much percentage roughly is?
50%.
50 to 60% of the affect mitral valve. And then next common will be what?
Common will be mitral plus aortic.
Very good.
40%.
That is about 20%, it will be about. And the other valves are isolated aortic valves, always less than 10%, maybe 5%. You say it's okay. Then tricuspid valve. The right-sided valves are extremely rare. And tricuspid valve, it's usually secondary to severe pulmonary hypertension, a functional TR. Which condition makes the right side valve more?
Sorry, sir, I didn't get you. Which question?
Huh?
Sorry, sir, I didn't get your question, sir.
Some lesion like a carcinoma that affects mainly the tricuspid and the pulmonary valve, not the rheumatic. Okay. So, how do you differentiate between aortic stenosis and mitral stenosis of rheumatic origin and aortic and mitral valve disease in a degenerative heart disease?
One is based on the age, sir. Rheumatic will
Yeah,
present
it goes
on
by
the
the age.
yes.
By the age, yeah.
Rheumatic will present the early age around 40, third decade to fourth decade, sir. The regenerative will be
You say in India 40 and 30 because there's a rapid deterioration of rheumatic valve disease in India, but in Western countries it's a 40 to 50, and above 60 it's usually like a regenerative, degenerative valve disease. And there's actually the anatomical difference between aortic stenosis of a degenerative and aortic lesion in a mitral, in a rheumatic, and in bicuspid aortic valve. What's the difference? Valve anatomy. Usually, what is taught is actually in a degenerative valve, it's not the commissure that are fused, causing the severe aortic stenosis. It's the whole valve cusp are thickened and degenerated, so that's the cause. The commissures are not affected. The rheumatic starts with the fusion of the commissure. And in bicuspid aortic valve, the most important thing is it's always very heavily calcified, much more calcified than the rheumatic degenerative valve disease. So these basic things.
Does your echo give you a clue for your cardiomegaly?
yes, sir.
All the dimensions of the
The LVAD is 45 and septal thickness is around 16. Only these two and the results.
That means you didn't see the echo report closely.
No, sir, the ID is 45, sir, and septal thickness is 16.
Sorry, sir. There is additional pericardial effusion mentioned in your echo. And
Yes,
that
sir.
may be the cause for your cardiomegaly on the X-ray. Right? In multivalvular disease, it is common to have pericardial effusion. More so with rheumatic heart disease. That is why I asked you how alert and how this thing meticulous you are in looking at your preoperative investigations. All right. And you also mentioned some amount of significant AR, moderate AR, I think.
Yes, sir.
So
Yes, sir.
that you might have missed it clinically, but it's okay because you said there was wide pulse pressure. You look for peripheral signs of AR.
Yes.
If I remember right in your presentation.
so
Yes.
that's it. Yeah, okay.
Okay, does this patient require operation, intervention?
Yes, sir. Patient is
Why?
symptomatic and be presented with restenosis, mitral restenosis. And the patient already has angina and syncope. So the natural history doesn't suppose we have to intervene.
Okay. So if he requires intervention, what will you advise?
So I will advise double valve replacement with mechanical bileaflet valves. Yes, sir.
How old is
50, sir.
50? What is the
Yes, sir.
natural history of double valve replacement? Average life expectancy after a
10
double
years.
valve?
After double valve, 10 years survival is around 40%.
So you are going to be converting valvular heart disease to prosthetic valve disease.
Yes, sir.
Double valve survival is not very great. You must be aware of that. Okay. Anyway, what valve are you going to choose?
I will use Onyx bileaf, mechanical bileaf.
Why mechanical?
This is 50 years and she's on atrial fibrillation, so she will require anticoagulation anyway.
She is already on anticoagulation. Okay. Yeah, sometimes examiner will ask you questions which may sound stupid, but you may have to answer them. Okay. So, all right. So why Onyx? Because patient is from Bangladesh. Onyx I thought was an expensive valve.
Onyx hemodynamics are good, sir, so I would suggest Onyx. And at the end, it's patient's choice to decide which valve to go. I would suggest Onyx valve. It's a better hemodynamics.
Yeah, but for curiosity, for my own this thing, what are the prices of these valves that are available now? How much does St. Jude cost? How much does Carbomedics cost? How much does Onyx cost? And how much does Chitra cost? Do you know?
Yes, the Carbomedics and St. Jude and Carbomedics both are around 80,000 in our institute. Around 80 to 90,000. And Chitra valve is a little lesser, sir, around 60,000. And Onyx valve is a little costly, sir, more than around 1.5.
So if you are doing a double valve, you will need 3 lakhs for the valves only.
Yes.
Yeah, comparatively very much lower than TAVI. TAVI is some 25 lakhs.
Yes, sir.
You mean to say you select Onyx valve because the orifice area is good? What's the primary criterion of selecting the Onyx valve? So basically, the reason is
lower anticoagulants.
Lesser anticoagulants is required, and the anticoagulant related complications are much less in Onyx valve. I don't think you select because of the hemodynamics. The hemodynamics of the St. Jude is good. What level of INR you want to keep in aortic valve, in other prosthetic valves, and in Onyx, in mitral and aortic prosthetic?
Other prosthetic valve will maintain 2 to 2.5 INR, sir. In Onyx, we will maintain on 1.8 to 2.
That's a great advantage.
Yes.
And generally, you want to keep a higher INR in all prosthetic mitral valves and less of that in aortic valves.
Yes.
And in Western literature, they say for a mitral valve, 3 to 4 or something, but that's not the practice in India.
Yes, sir. We maintain on 2.5 to 3.5.
Yeah, that's right. So how are you going to proceed with your operation?
Sir, I will go with midline sternotomy, double valve replacement, sir. So after general anesthesia and midline sternotomy, I must be resected and pericardium
This
open.
patient is on anticoagulants. When do you want to stop it?
I would like to stop warfarin for 5 days before and bridge with heparin, sir. And then stop heparin the previous night of surgery.
Okay, then.
And then advance the midline double valve replacement. After median sternotomy, will give heparin to achieve ACT of more than 480 and aortic bicaval cannulation. And I will do LA approach in this case of a mitral valve. So I will just loop, I will say loop and keep. And I will, after heparin, once the ACT is more than 480, will go on bypass. I will give root after transplant.
If you say that the initial stage, you put a transesophageal echo and look for clots also, because a transesophageal echo is much better than a transthoracic echo to bring out clots in the left lifting appendage. So that if you know after TE the clot, you can be more careful in manipulating the heart before aorta cross.
Yes.
Okay. Then we reach sternotomy.
Yes, aortic bicaval cannulation with the ACT of 480. And then once everything is ready, I'll go on bypass. And before cross clamp, I'll fibrillate the heart and then cross clamp, and I will give direct arterial cardioplegia, sir, because of the AR.
Yeah.
And I will, yes. And I will vent the heart through that LA into tail group. And first I will excise the aortic valve and then size the valve. I will give J-shaped aortotomy in this case, sir, because the root annulus is 18 mm only. I may have to do root widening. So I will give J-shaped incision and then excise the aortic valve, size the valve. And then I will open the, I will expose the mitral valve, excise the mitral valve, look for the LA clot, and then excise the mitral valve and replace the mitral valve, and then come and replace the aortic valves. Let me see.
You must know what are the implications and problems that you get when you're doing a double valve replacement along with root widening.
Yes.
Okay.
Yes.
How do you manage that? What is the implication of root widening, and especially when you're trying to put in a double valve? The technical details you must know.
Yes.
Attempt the measurement of the annulus by an echo. Transthoracic may not be correct. So don't jump and say, I will do root widening. So you see that after cross clamp, the vent, cross clamp, and open the aorta, and then after excising the aortic valve with precaution, putting a gauze swab into the left ventricle so that the calcium, and then after that you measure the annulus again. If it in a lady of 50 years, if we can put a 19 millimeter valve, general understanding is that no need to do a widening. So, instead of jumping and say I'll do root widening, you do all the excision, all the calcium, and things like that, and then measure again whether you can fit in 19. If not, then of course you have to think of root widening.
But you were right in saying that you might have to do, so you will probably go through a J-shaped incision, because in case you need it later on, you can extend it. That is important. So you must pre-plan this.
Yes.
Okay. What is your myocardial protection strategy?
I will use both direct arterial cardioplegia and retrograde cardioplegia in this case. Save the cross clamp time.
How much will you cool?
I'll cool to 28, sir. As a routine, this thing, I'll cool to 28. This thing, this is a double alternating time. I'll cool to 28, and then I will give a cardioplegia 20 ml per kg dose.
Hmm.
And I'll dilute a cardioplegia and repeat after every 16 minutes.
Hmm.
And then after the procedure, I will give hot shot to wash off the electrolytes and metabolites.
Hmm.
And then I'll try to come out and rest the heart for 1/3 of my clamp time. And then I'll start coming out.
Okay. What other problems you anticipate in this patient? Heart blocks can be a problem.
Yes, sir. Heart blocks.
Okay.
Yes, sir.
There's calcification. It's calcification on the aortic annulus.
No, sir. Not on the annulus, sir. Only on the leafless. Annulus.
Okay, that is one of the things that can happen in a multivalvular lesion and more of the aortic valve. So heart blocks, low cardiac output post-op.
Yes.
Yeah.
Yeah.
In this case, what type of root widening will you prefer?
I will prefer Nix. I can go one size way higher than, sir. So I prefer Nix in this.
Nix procedure is much easier to do. And so in this case, already the root is 18 millimeters. So you need to do only the easiest method because root widening is not a simple procedure.
Yes.
So select it according to the annulus diameter. If the easiest being next procedure, what is the next procedure? It's common then.
Excuse me.
Sorry, sir. Pardon, sir.
Most commonly done is Nix.
Nix, sir.
What else have you seen?
There's a Manujian, sir. We'll go mostly the NCCLC this thing.
Where is the incision in Manogia? What part?
It will be at the NCCLCC commissioner junction at the base of the AML, sir. And then otherwise Roscono, that will be a last option because it will be OTA.
Yeah. That is the most complicated because you have to cut the aortic annulus, the anterior part of the left ventricle, right ventricle, then the septum. So you have to do all those, repair all those. So it's the most complicated and gets probably can put a bigger valve.
Yes.
But the procedure is so complicated, most people do either Nix for most cases and the Manujian procedure for other cases.
Yes.
But and everybody give both retrograde and antegrade cardioplegia in this hospital.
No, sir, not everyone.
Yeah.
Like all.
When you excluded the coronary artery disease, it
Yes,
may
it's
be
not.
okay.
Yes, sir.
Antegrade, direct osteocardioplegia may be all right, except that because there is concentric hypertrophy, you have to give an increased dose also.
Yes, sir.
Anybody else has any questions to ask?
How do you define patient prosthetic mismatch.
And calculate for body surface area into 0.85 multiplies if that anything under less than that, it will be a
Above 0.85 is normal. You don't say there is any
yes,
ppm.
ppm.
And there's moderate ppm and a severe ppm. What are the criteria?
Severe ppm is less than 0.65, sir.
And between 0.85 and 0.65,
It's a
the
moderate.
moderate ppm. What cardioplegia are you using now? In our hospital?
Again, it's surgeon's preference, sir. Like Praveen sir and the who practice for a long time, they are using St. Thomas, sir. And currently, the news is just slowly shifting towards the Del Nido.
Del Nido, how often do they repeat in this?
Ideally, they're waiting till 90 minutes. Sir. Based on surgical steps, we have somewhere between 70 to 90 minutes, they are repeating, depending upon. Ideally, 170 minutes, and they are ready to give.
In nowadays, we only knew St. Thomas's solution. Okay.
Yes.
So, but now that you have the different types, you must also know the composition of the different types and the pros and cons.
Yes.
Del Nido, Custodiol, and St. Thomas's. Okay.
Yes.
And they may ask you, when will you use what cardioplegia? Because Custodiol is generally used for transplants, I think, if I'm not mistaken.
Yes.
Yeah. For clinical, usually people don't use the custodial cardioplegia. Del Nido was originally discussed for pediatric cardiac surgery because he's a pediatric cardiac surgeon in Boston Children's Hospital. That's after him. Nowadays, later on extended to the use in adults also.
Pericardial effusion in this case, how much is usually the significance? They mentioned 3 mm superior to RA and 3 mm postulateral to LV.
Most of the multivalvular disease will have some amount of pericardial effusion. So that is of not much of significance. You just have to drain it. Once you open the pericardium, it gets drained. You don't have to be bothered about it. But it can present as huge cardiomegaly on the X-rays and the ECG. I mean echo. So that is important.
In that case, apical impulse also will be shifted, sir, like in the again.
Apical impulse will be masked. If there is significant pericardial effusion, it will be masked.
And the cardiac circuit and X-ray also will be different for the pericardial effusion. Rather than the LV type or pulmonary artery prominence. So it's quite different from the X-ray appearance of pericardial effusion. So from the chest X-ray, you won't think there's much of a pericardial effusion. It's an echocardiographic kind.
And since this patient is being AF, should we in surgical step, should we say MACE as a resting surgery? We will do double replacement plus MACE, or we can avoid saying MACE. In our institute, we are using only PVIs actually. MACE not everyone does.
It depends on the LA size. If you think that LA is pretty big, then you will probably do, and as you said, pulmonary venous isolation.
Okay.
Nobody does MACE anymore. I don't think anybody does maze anymore.
Because in our part one exams, Prasanna Simha, he was the examiner. When we said this MVR plus pulmonary valve isolation, he didn't agree. He said that and all done long time ago. Now we have to say maze. He asked more about the maze, all those things. I don't know, Sada, what to say in that.
You
You
can
say
just say, you see, in such a situation, you just have to agree with your examiner. But you can also say, sir, we don't do a maze in our institution. We do only pulmonary vein isolation. That's it.
Oh.
And agree to whatever she says. So don't, for heaven's sake, don't argue with your examiners.
Yes.
All right. So
Yes, sir.
if you don't know something, or if he contradicts you, just agree to it. Bus. Your whole idea is to pass that exam.
Yes.
Okay, you are not going to have a tussle between you and the examiner. So you just
Yes.
be diplomatic, agree to whatever he says, and then fine. That what you do, what you think, or what you do later on in life is different matter.
Yes.
All right.
Yes, sir.
with a double valve replacement, most people will not do a biatrial maze. So the general practice in this hospital is to do a pulmonary vein isolation with actually a transverse ablation from this circular pulmonary vein isolation to the mitral annulus by cryo or whatever it is. And that's actually in this hospital, Dr. P.V. Rao said about at the end of 1 year, about 90 to 92% of them are in sinusoidism. So that is good. That's a general practice in this hospital rather than doing a biatrial maze along with double valve replacement, along with root widening, all those. So that's a common practice. But if the examiner asks, you can, of course, say you can do biatrial maze, conduct complete review. But practically, this is what is done in the job.
Yes.
If you could see,
Amulya, this is part of your thesis. Can you enlighten us a little more about the pros and cons of maze versus pulmonary valve isolation?
Morning, sir.
mine.
LA maze as such, both biatrial maze, it's a prolonged procedure, sir. So that's why unilateral maze is preferred. In case of pulmonary vein isolation, only going around the pulmonary vein isolation, pulmonary veins is done. So that itself is again less time consuming. But cut and sews technique, it comes with its own cons of bleeding and in the current era, they do uh, maize force, which is mostly um, energy source dependent. That they use either bipolar or radio frequency and cryoprobe, depending on the site of the lesion. That is. Bipolar is used around the pulmonary veins, and cryoprobe is only at the select areas like mitral isthmus and near the tricuspid valve, that is tricuspid annulus, that is at 2 o'clock and 10 o'clock. Elsewhere, it is either bipolar or a radio frequency clamp that is used. Radio frequency clamp and bipolar, one disadvantage is that if it is not transmural, it is not effective. There it should be applied for about less than 2 minutes, but radio frequency clamp, they come with the alarm and timing set, that how much is applied and whether it is transmural or not. But other things, they do not generally tell you whether it is transmural or not. And cost effectively being, our surgeon uses only by unipolar cautery as well to do LMAs. Generally doing unilateral maze, it is less time consuming, and CPP time is less as compared to the biatrial maze. And the macroelectrons circuits are more the origin of the macroelectric currents are more around the pulmonary vein and near the LA appendage. So if you tackle this, that is more than enough, and RA is not required.
And what was your long-term result? You said 85%, no?
Yes, sir.
That is for what was your longest period of follow-up? 2 years?
12
3
months.
years? Huh?
3 months, 6 months, and 12 months.
12 months.
Yes.
Any questions or comments?
I see there are 1 or 2 people from MIOT who have logged in. Is there anybody from your batch going for exams?
Yes, sir. We have a person here.
Huh?
Yes, sir. We have a person here.
So exam going people should take a little more active part in these discussions. You know, you have to learn to talk and ask questions or participate in the discussions. So
Okay, sir.
you should be this thing. The whole idea of these classes, especially for exam goings, is that you get to know how to talk in the exam, answer the examiners.
Yes, sir.
You should be a little more actively involved.
Okay, sir.
Yeah. Anyway, there's only 1 week left now. Less than a week.
When is the exam?
8th of October.
Tuesday, sir. Coming Tuesday.
In New Delhi, is it?
No, sir. Chennai Apollo, sir.
Is it? Oh, okay.
Okay.
Okay, wish you all the best. All the exam going.
Thank you, sir.
Thank you.
All right.
Thank you,
Thank
sir.
you. Thank you, sir.
Thank you, sir.
Thanks, everybody.
Thank you, sir.